I'm going to present this study. The results aren't published yet, but basically we were looking at evidence for childhood adversity in lifetime hospitalizations in Scotland, and whether there was an association with suicide later in life. The study started before COVID, so it's sort of been interrupted by COVID, and it's my first time presenting these, so there's quite a lot of material, and I hope I'll be able to get through all of it in the time. A little bit of background to this. First of all, we know that childhood adversity is associated with poorer health outcomes, including suicidal behavior. And we know that up to a quarter of deaths by suicide occur shortly after a discharge from hospital. So in this study, we thought whether hospitalization record might be a good place to look for factors associated with suicide. In Scotland, inpatient hospital data are available from 1981. This means that we can have sort of an entire lifespan analysis for young people who died by suicide. So for somebody born in 1981, at the end of our study period, they would have been aged 36. But also going into the study, we expected that childhood adversity codes in hospital records would be rare and likely underreported, because adversities that sort of show up in hospital are probably only the kind of severe end. And there's also a relatively high threshold to reporting them in hospital, because for things like childhood maltreatment and neglect, it triggers a whole host of safeguarding mechanisms. So a clinician needs to be really certain this is what they're seeing before they trigger everything. So the aim of this study was to analyze lifespan hospital records of young people who later died by suicide and compare their records to the general population with regards to records related to childhood adversity, mental health, and suicide. I've listed two of our research questions here that I'm going to discuss today. The first one was about the relationship between the number and type of childhood adversities and suicide. And the second one was about the dose-response relationship between the number of adversities and suicide, and whether the different kinds of adversities that we observed can be ranked in terms of how much of an impact they have on suicide later in life. I'll talk about the methods next. So we define childhood adversity relatively broadly. This is to have a sort of maximally sensitive approach to something that we thought would be quite rare in the data. So primarily adversities were defined in terms of diagnosis codes in ICD-9 and ICD-10. These were either maltreatment and violence related codes. These were defined in a previous UK study. We also used codes suggestive of maltreatment or neglect that came from a really interesting US study in emergency departments. Basically, these would flag up a hospital record where there was an injury to an infant, for example, without an accompanying code for an accident, or say for something like a code for malnutrition, where there wasn't also an organic disorder that would explain the malnutrition, and therefore it's reasonable to think that it's a case of neglect. We defined mental health related codes in terms of a big list provided by the clinical classification software, CCS. This basically just divides the entirety of the ICD catalog into discrete disorders, including mental health. And then within mental health, it also subdivides it into things like self-harm, mood disorders, anxiety disorders, and so on. Another group of adversities sort of came out of data exploration. I've called them data-driven here. The first group of these are accidental poisonings. These turned out to be associated with suicide, in addition to intentional poisonings, which count as self-harm. So they were included. And another category was place of residence based. So every hospitalization is tagged for where somebody was admitted from or discharged to. And there's a very sort of infrequent number of categories for things like residence in prison or a legal institution, or sort of an other place of residence, which we suspected had to do with a place of care. And we combined this with another category, which was for having no fixed abode, because both of them were relatively rare, but both were associated with suicide, it turned out. And then finally, there's this category of intergenerational trauma, because in addition to records pertaining to individuals who died by suicide, we were also able to link their mother's hospitalization data and their death records. So we were able to include things like maternal bereavement in cases where somebody's mother died, and also maternal adversity, although this is still a work in progress, and I'll explain this in a bit. I'll skip this slide, which is about the cross-mapping from the USA-based ICD codes to the UK-based ICD codes, because I don't really have time to discuss these details. So on to the data that we used. So we started off by extracting death records for individuals who died by suicide in Scotland. These were people who were born in 1981 or later and who died by suicide at age 10 or later in the period 1991 to 2017. And then these were our cases. And then for our controls, we extracted 10 times as many patient records who were matched on age, sex, and postcode, and were also alive at the time of the case's deaths. So these form our cohorts, to which we then were able to link hospital admissions for physical health, psychiatric admissions, and also maternity data, which then further linked to the mother's identities, from which we were able to get the mother's death records, hospital admissions, and psychiatric admissions. And like I said, only some of these have been analyzed so far, and I'll present today. So so far we've done the adverse events in the individual's hospital records, so this side of the graph, and we've done the maternal bereavement before age 18, but the maternal adversity is still a work in progress, so I won't be able to present that today. So moving on to the sort of top level results, we were able to extract records for 2,477 cases of people who died by suicide and 10 times as many controls. And then we sort of took a subsample of those based on people having at least one inpatient record prior to death, just so that we can condition the analysis on somebody being seen in hospital and then a clinician being able to see some of these factors that we're studying. So about 85% of people who died by suicide were able to be included based on this criterion, and only about 55% of the controls. So in some sense, we already see that people who go on to die by suicide were more likely to have had at least one hospitalization in their lifetime. In line with previous studies, we found that about 3/4 of our cases were male. The average age at death was just under 24. And interestingly, those without any hospitalizations before they died approximately 2 years earlier. So in a crude sense, it looks like having a hospitalization is protective against death by suicide. And then looking at the deprivation gradient, we see there's a gradient towards the more deprived areas using the Scottish Index of Multiple Deprivation. Nearly 40% of our cases were in the most deprived area. And then also about 3/4 of the cases came from urban areas as well. This is compared to about 70% of the general Scottish population living in urban areas. Next, I'll talk about the frequency of these adversities. So what this slide shows is odds ratios for the individual adversities and the different ages that they were observed. This is done independently of each other. And I should also point out that at the start of this project, we expected to see sort of a timeline where we expected to see adverse events happen in childhood, so up to age 10 or so, followed by mental health conditions from in adolescence, so 10 to 18 or so, and then that would be followed by suicide. But it turns out that adversities were relatively rare, so the data were too sparse to sort of test out this temporal hypothesis. So what this shows is just the frequency of each of these adversities happening. And I've also sorted them in descending order of odds ratio. So interestingly, we find that accidental poisoning comes out on top in terms of odds ratio, with nearly 13% of cases having at least one episode of accidental poisoning in hospital. The second most common adversity, or the second highest association with suicide, was with mental health related diagnosis. And this included self-harm and intentional poisoning. I've made this bold here because there's quite a striking sex difference as well. So for females, it's nearly 30% of cases who died by suicide that had at least one mental health related diagnosis in an inpatient hospital episode. This was followed by care experience or having no fixed abode. These were quite rare, with only about 3% of cases before age 18. And then followed by maltreatment and violence related diagnosis. We looked at these separately by age. So in childhood, they were relatively rare with a sort of 1.6 odds ratio, and that they increased in adolescence, so between ages 10 to 18. where nearly 8% of cases had experienced that. And there was a sex difference here as well, with more male cases having experienced maltreatments or violence-related codes. This probably has to do sort of with a shift from adversity experienced at home during childhood to a shift towards sort of peer-to-peer violence or gang violence, bullying, that sort of thing happening sort of later in a child's life when they enter school and adolescence as well. And then finally, we have maternal death, which was also relatively rare, with an odds ratio of about 2. And then the codes suggested.
1 minute.
Oof.
1 minute, Chair.
Okay. I'll try and speed up then. So we've got finally codes suggestive of maltreatment or neglect, which were found to be significantly related in US-based studies, but not in UK-based studies. And I don't really have the time to talk about the contextual differences that probably explain this. On the next slide, we combined all of these and put them into logistic regression to test out sort of the adjusted odds ratios, in which case the top category that came out was a diagnosis of self-harm. So what we did for the logistic regression was subdivide the adversities where they were more common into sort of their top categories. So for mental health, we looked at self-harm, alcohol-related codes, and everything else that wasn't self-harm or alcohol-related. And then for maltreatment and violence-related codes, we looked at assault or maltreatment codes separately from what we've termed adverse social circumstances or events of undetermined intent. And it turned out only assault or maltreatment was a significant association to suicide. So interestingly, in contrast to the adversity seen in isolation, once you've combined all of them, the most significantly related ones to suicide were self-harm. And then differently for males and females. For males, the next most common, most strongest association was having 2 or more episodes of any mental health that wasn't self-harm or alcohol related, and then followed by an alcohol-related mental health diagnosis. Whereas for females, the next 2 strongest associations were having care experience or no fixed abode, or having a code of assault or maltreatment. All of the rest of the adversities here that I've presented sort of had an odds ratio between 1.5 and 3. So finally, to conclude, what we found was that childhood adversity events, in particular self-harm and other mental health related episodes, were associated with death by suicide, even after multiple adjustment. We found that codes suggestive of maltreatment or neglect were not significantly related to suicide, and that's probably due to contextual differences between the countries. The strongest association we found was for self-harm, but we also found that accidental poisonings were associated with death by suicide. In all likelihood, this is probably because some proportion of these accidental poisonings are likely to be intentional poisonings that were misdiagnosed, or sort of there wasn't enough data to treat them as intentional in the case notes. We found, as we expected, that childhood adversity events were relatively rare, with mental health related episodes being the most common ones. And again, this is likely an underestimate because only the most severe cases get hospitalized. And then finally, a more general point about administrative data being a valuable resource for studying suicide. In this case, we were able to extract lifetime records, and there's further opportunities for linkage. So we're still working on analyzing the maternal data. We know from National Records of Scotland that it's now also possible to link paternal data, and we could probably link in data from siblings as well, so we could get quite a rich sort of family history of adversity and so on. And that's me. Thank you very much, and thank you to my co-authors as well.